Hello, I'm Dr. Cheryl Clark, Director of Health Equity Research and Intervention in the Center for Community Health and Health Equity at Brigham and Women's Hospital. And today I'll be talking about an emerging topic for the boards, bringing health equity into clinical practice. And I have no disclosures to declare. Today's presentation will review frameworks for incorporating health equity into clinical practice. I'll start by giving us some definitions of differences versus disparities versus inequities that'll guide our discussion. And today, our topic focus will be health equity in COVID-19, including defining equity in a global pandemic, addressing health-related social needs as a part of clinical care, and lessons learned for equity that we learned during the COVID-19 pandemic. A few take-home points. Addressing equity requires attention to social and medical contributors to health and healthcare delivery. Effective clinical care requires community and stakeholder engagement to address social and medical contributors to health. And importantly, there are strategies that we can use to improve disparities and inequities in clinical practice, and we'll focus on those as a part of this talk. So let's begin with definitions. What is a difference in health? What is a disparity in health care? And what is a health inequity? To do this, I'm going to draw from two seminal textbooks. One is Unequal Treatment, Confronting Race and Ethnic Disparities in Healthcare. And the second is Closing the Gap in a Generation, Health Equity Through Action on the Social Determinants of Health. And we'll describe those in a moment. So to begin, let's do a question. Using the National Academy of Medicine framework from Unequal Treatment, which of the following is a healthcare disparity? Differences in prescribing hormonal therapy for breast cancer between Black and white women. Differences in opioid prescribing for chronic pain by race or ethnicity. Differences in patient preferences for skilled nursing facility use post-hospitalization by race or ethnicity, or differences in opioid prescribing for acute long bone fracture by race or ethnicity. And I'll pause for a moment to give you a chance to select an answer. Which answer did you select? The choice that I would have you make is D, differences in opioid prescribing for acute long bone fracture by race or ethnicity. And why would that be? Using the National Academy of Medicine framework, a disparity is defined in the following way. A disparity is a difference that is not due to clinically appropriate care or patient preferences. Contributors to disparities include a lack of interpreters, time pressure, payment models, and insurance coverage, all the sort of things that contribute to the way that our health systems operate, but also the parts that can creep in when we're not sure what to do, when there's uncertainty in care, including bias and stereotyping. These are factors that contribute to differences that are controllable and things that we can do something about if we structure healthcare delivery and incentives differently. So they're not due to the clinical needs of the patient, appropriateness, or the patient's preferences. So let's use this framework to answer the question that we posed in question 1. Differences in prescribing hormone therapy between Black and white women. That's not the answer in this case because we really do need more information about the biology of the tumor to determine whether this is clinically appropriate care. We understand the epidemiology of breast cancer indicates that women who are Black and self-reported Black ethnicity tend to have triple negative cancers in terms of their hormone status. But we should also make the very important point here that race is a social category and not a biological category. So in order to know whether the care here is clinically appropriate, we really need to understand the biology of the tumor in order to know whether this is a difference or a true healthcare disparity. The second question, differences in opiate prescribing for chronic pain by race or ethnicity. This answer isn't the best answer because prescribing opiates for chronic pain is now thought of as overprescribing or overuse. And in this context, this would not represent appropriate care. Differences in patient preferences for skilled nursing facility use post hospitalization may be appropriate, as it is appropriate to have patient preferences guide care. But we should also be careful about the ways that clinicians shape patient preferences. The answer here is a classic example that's used in unequal treatment to talk about the differences in the way that we perceive patient pain and patient symptoms and how that can sometimes happen by race ethnicity. In this context, acute pain, including pain that happens from fracturing a long bone like a femur, should be treated with appropriate therapies. And so that is why this is a healthcare disparity if we notice that there's difference in prescribing for acute pain. So what can we do to address disparities? A 2018 article in Health Affairs lays out several principles that are very applicable today, including using population health data to try to identify differences in clinical needs in diverse populations, standardizing care to minimize uncertainty, expanding the diversity of the care team to check bias and discrimination, as well as incentivizing change through payment models in the way that we pay for care. This was all very true in a pre-COVID or coronavirus environment. There are several challenges that are now emerging in a coronavirus or post-COVID environment that we need to consider, including what we should do when we can't standardize care and when there is great uncertainty. I think increasingly we are finding that coronavirus in particular has had a disproportionate impact on Black and Latinx communities. And we have found this out as a healthcare community, humbly so. Much of the early reporting actually happened through journalism, where we found that our reporting systems and our data collection systems may or may not have been adequate within healthcare to really detect these differences in an early way. And this report from one of our national newspapers, the Boston Globe, reported on this information and sort of heightened our understanding of this in our healthcare system early. And so I think increasingly we are finding that we need to start relying on a different framework, closing the gap in a generation, to properly prepare ourselves for managing these inequities in the context of COVID infection. So let's move to our second and last question for the day. According to the American College of Physicians' April 2018 physician paper on addressing social determinants of health, which of the following is most likely to address a healthcare inequity? A pop-up tent delivering SARS-CoV-2 tests and food in a community center parking lot. Tracking enrollment into hospital-sponsored remdesivir trials by race, ethnicity, and preferred language. Providing virtual care electronic tablets to improve non-English language access. Subsidizing the cost of in-home childcare for non-clinical employees to $3 an hour, or all of the above. And I'll give you a moment to answer this question for yourself. Which answer did you choose? Closing the gap in a generation, I would recommend that all the above are appropriate answers to this question. And to understand that, let's understand what are social determinants of health using the World Health Organization framework. A social determinant of health are the circumstances in which people are born, grow, live, work, and age, the systems put in place to deal with illness, and an understanding that these circumstances and systems are shaped by economics, social policies, and politics. So then, what is a health inequity? The World Health Organization framework defines health inequities in the context of human rights and social justice. And it's defined as differences between individuals and groups that are avoidable and unfair, and that arise from social and economic conditions within and between societies, and that differences in illness in this context are contingent on social and economic actions taken to prevent and respond to illness. And we can see that the foundations for social determinants of health exist in many parts of society, including maternal and child health, environmental conditions, fair employment and safe work leading to living wages and occupational conditions that are safe, social safety net protections, making the healthy thing to do the easy thing to do in society, fair financing, including a progressive tax system, prioritizing the rights of women and other populations that are historically have faced inequities in care, as well as importantly collecting and monitoring data. What we found within our healthcare institution is that defining equity during the response to the COVID-19 pandemic required us to create an additional definition of equity to help us guide our response in diverse populations. And in this context, equity during a COVID crisis is defined in the following way. The needs of the few and the vulnerable are in balance with the needs of the many and powerful. In this context, we know that we have achieved equity when we centrally integrate equity into the way that we define problems, the way that we make decisions, and the processes and outcomes of all of our activities in healthcare, including our operations, our planning, our logistics, and our financing of healthcare. And I'm going to tell you a story about how we at Brigham and Women's Hospital and our parent operation, Brigham Health, responded to COVID-19 within our own healthcare institution. And what we learned is that it was necessary to use both of these frameworks to address policy, advocacy, and structural change, community health, employee equity, and all of these were necessary to accomplish patient care equity. To do this, we had to stand up several work streams that addressed employee equity, community health, access to care, data and monitoring, communication and engagement with patient and employees across language and digital divides, as well as a policy and advocacy work stream. And we embedded these equity roles into our hospital incident command system leadership structure so that we were able to nimbly respond to needs within each of these work streams as they came about. And I'd like to share some highlights. Highlights related to patient care, including ambulatory outreach for social determinants of health, including inpatient language access, inpatient population health, COVID data monitoring, monitoring access to remdesivir within our healthcare institution, community health testing and social determinants of health partnerships to address food insecurity, employee broadcasts and other ways that we communicated equitably with our employee population, employee equity, childcare reimbursement, and education sessions that were also a part of employee equity, and policy, including crisis standards of care. And I'll also allude to an emerging area for our institution, which includes virtual care and making sure that access to virtual care is equitable and also incorporates language access. At the beginning of the pandemic, one of our hospital licensed community health centers, Brookside Community Health Center in Jamaica Plain, Massachusetts, was very proactive in reaching out to our primary care population. Several issues emerged, including the issues around food insecurity, medication access, and other factors that patients needed to be able to shelter in place safely and still have access to their medications and resources like food. So our executive director and medical director and staff reached out by phone to make sure that they called all of our patients who are high risk within that clinic, to make sure that they had these resources in place, and also to make sure that our patients know that they can come in and get care if they need it, including coronavirus testing, and that that care would not count against them should they be concerned about documentation or federal changes around public charge rules. Additionally, within our accountable care organization patient population, there is a multi-layered approach to doing this proactive outreach. Dr. Kristen Price at the Brigham and Women's Hospital is our director of our primary care Medicaid accountable care organization in Massachusetts at our hospital, and organized a call to all of our patients who were high risk due to medical conditions, including adults age 80 and older with any frailty indicator, adults age 70 and older with respiratory diseases and other comorbidities, and those who were also high risk due to social conditions. So those who were age 30 and older, but who lived in a zip code or who had clinical conditions that were early on associated with susceptibility to coronavirus infection. Additionally, phone calls were made to high-risk communities and testing sites were put in place to make sure that our patient populations and our surrounding communities had access to coronavirus testing, as well as equipment needed to shelter in place and to prevent infection. And what was found as a part of this, and as a part of doing data collection that included social determinants of health screening, is that there was an enormous amount of food insecurity within both our patient population as well as within local communities in Boston. For example, social determinants of health screening that was done in our health centers prior to coronavirus showed that 19% of people were worried that they might not have food to eat, or that food would run out before they could afford to buy more. This increased in our community settings to 28% during the pandemic. So it was very important that we use the principle of community outreach and community engagement to bring coronavirus testing as well as equipment and food into community settings. What you see in the slide is a photograph of one of the community pop-up testing sites where physicians and staff and clinical staff used in a pop-up RV to provide SARS-CoV-2 testing to community residents, and also to provide boxes of food, to provide care kits that had masks and other ways of helping patients to become educated around how to protect themselves from coronavirus. And additionally, home food delivery was established for patients who were not able to, patients and community members who were not able to shelter at home and still go out and have food brought to them. And we also recognized that this was an opportunity for civic engagement. Voter registration was also offered and is currently ongoing, as well as making sure that maternal and child health is incorporated into the equity response by distributing diapers and wipes to those who need it. In addition to this community health outreach, communicating equitably with healthcare employees was also a central part of our healthcare response. Our director for the Center for Diversity and Inclusion in our hospital organized efforts to make sure that we communicated in multiple languages with our healthcare employees. And what you'll see on this slide is one of the first times within our healthcare organization that emails were delivered to our employees in multiple languages to make sure that staff had access to information on coronavirus processes within our hospital, as well as opportunities for stress relief and for counseling to help them manage stress associated with providing care during the pandemic. Another important part of taking care of our employees, as we ask our employees to take care of our patients, is making sure that we think about advocating for affordable childcare. Ms. Normella Walker and Dr. Karthik Sivashankar were instrumental and working with our corporate institution to provide access to childcare that was affordable for in-home childcare. As a system, we also were very attentive to making sure that access to equipment, including protective equipment like masks and face shields, were provided to all healthcare staff, irrespective of their role, to make sure that we thought through the digital divide and that we communicated policies and gave updates to our employees and did it in a way that allowed employees who did not have access to electronic devices or electronic mail would also get those broadcasts, and that we connected employees with resources that they would need to help take care of themselves as they take care of patients. So as we take care of our communities and community health activities, as we take care of our employees so they can take care of patients, that allows us to think more deeply about how we need to provide equitable care to our patients. One of the key parts of doing this is making sure that language accessibility is a part of our care for patients. We realized that being in a scenario where we couldn't always touch our patients and we couldn't always be near them, we would need to optimize our workflows to provide interpreter services to our patients who had coronavirus infections. And that required us to both use our interpreters, but also to use new technology, including electronic tablets that allowed us to have interpreters phone in and use a visual and phone interface to speak with our patients. And we are now looking at how we can integrate interpreters more systematically into virtual care that's being increasingly used within our health system. We need to think about important intersectionalities, such as communicating across difference and communicating well with patients who have disabilities. And there are specific tips for multiple scenarios that we took into account, including tips for communicating well with patients who have mobility limitations, patients with low vision and blindness, and patients who have service animals. These tips and techniques were incorporated into our teaching and into our policies for working with patients and employees, even with disabilities. And finally, with respect to patient care, early in the pandemic, there were very few options for treatment. And it was important to make sure that even as we were testing the utility of various options, that we were doing that in a way that provided that care or access to clinical trials across difference and diversity. One of the important treatments that is emerging is treatment to antiretroviral therapy, including remdesivir. And in our hospital, we had early access to the moderate and severe remdesivir trials. Dr. Francisco Marti, who you see on our screen, provided care to make sure that the populations who had access to the trial in our hospital represented a diverse population, including those who were not English speaking and those from diverse racial and ethnic backgrounds. Additionally, we engaged in policy activities related to scarcity in resource allocation. We had hoped that we would not get to the point where we did not have enough ventilators or intensive care unit beds to treat patients. But if that became an eventuality, we wanted to make sure that the intellectual framework was put in place so that the choices around who was able to access that care did not disadvantage populations due to disability, race, ethnicity, or other factors. And so advocacy and dialogues were conducted at the level of the state and Massachusetts, and those guidelines were put into place to ensure an equitable response in that context. Taking all of these points into consideration, I think there is one summary point that's important to take away from our experience. And that is the power of multidisciplinary teams and community engagement in doing work to address health equity in clinical settings. Every one of the examples that I showed required hospital clinical leadership to be deeply engaged in the work, required resources within our clinical settings, including our community health centers, required volunteers and donors, including nonprofit agencies who provided access to food and other resources, as well as community partnerships and stakeholders who were key partners in making sure that we identified issues that needed to be addressed quickly and that we were able to respond in ways that patients and community residents could access. So what can we do to eliminate inequities in clinical care? Our example shows that the American College of Physicians statement in 2018 is still very relevant. There are 9 recommendations, including implementing policy interventions to promote health equity, that healthcare professionals should be knowledgeable about screening and identifying social determinants in practice, that we should use team-based care approaches, that we should invest in evidence-based programs and social services, support research and include diverse participants in research and clinical trials, that we support health in all policies and community planning, that we use electronic health systems to improve health and to understand data within our health systems, and that we adjust payment and performance metrics for social risks, as well as screening and collecting social data to aid evidence-driven decisions. In summary, health disparities and inequities are multifactorial, and they include social and medical contributors. And there's an increasing need to address social determinants of health and clinical care. Physicians are increasingly required to have the skills, knowledge, attitudes, and systems in place to address these issues. And this is definitely an important resource for us as we think about managing the uncertainty associated with the coronavirus and pandemic. So as we develop these new strategies to care for patients, we should take attention to data, building community partnerships, and other strategies that are needed to eliminate disparities and inequities as we've talked about. Here are some resources and references that you can use as you design your own strategies for incorporating health equity into your clinical practice, including resources from the Centers for Disease Control and Prevention that are provided for patients in multiple languages, resources for screening patients for social determinants of health and health-related social needs, and standards for federal data collection on race, sex, primary language, and disability status. Thank you so much for your attention. And I appreciate the opportunity to speak with you today.